Today, we're addressing a subject every clinician needs to know, but few discuss openly: how to spot signs of abuse in your patients and what you can do the moment suspicion strikes. In this episode, we will give you practical insights and clear steps you can use right away. Let's dive in and discover how your next exam could truly save a life.
Welcome to the Pillars Pod, where we explore the foundational values that shape exceptional dental professionals: excellence, ethics, professionalism, and leadership. Whether you're an ACD member, a dental student just starting out, a young practitioner finding your stride, or a seasoned dentist committed to growth, this podcast is for you. I'm Dr. Sonia Sluda, joined by my co-host, Dr. Saira Paradis, and together we'll be diving into a conversation with Dr. Frank Stechey around a topic that resonates with every stage of the dental journey: recognizing abuse in your practice and what to do about it.
Today's guest is someone who has really redefined what it means to be a dentist. Dr. Stechey spent over 30 years in family practice, but his impact stretches far beyond the clinic. From serving as team dentist for pro sports teams to volunteering at the World Trade Center after 9/11, his work in forensic and sports dentistry has served to protect and help countless lives. He's a passionate educator, a decorated community leader, and a tireless advocate for using dentistry to prevent abuse and promote public safety. With multiple fellowships and international recognition, Dr. Stechey brings a wealth of experience and heart to every conversation. Let's dive into the incredible journey of a dentist who has made service above self his lifelong mission.
Dr. Stechey, your career has shown us that dentistry isn't just about teeth. It's about people, protection, and sometimes even uncovering the untold stories behind a smile. In that spirit, let's start with something that is both powerful and practical. When it comes to recognizing signs of abuse or trauma, what clinical indicators, for example, pattern bruising and behavioral cues, such as hesitation or inconsistent histories, should dental professionals be trained to identify during routine exams?
Thank you, Sonia, and thank you so much. The clinical signs of abuse for all healthcare professionals, not just dental, but any healthcare professionals, are basically both objective and subjective, and clinicians must be sensitive to even the smallest of these signs. Objective is what one would see. So the clues there that are unique to the dental healthcare professional is that 65% of all physical abuse and trauma is in the head and neck areas. That's our domain. Another 24% is in the arms and limbs. So easily 89% is viewed by any healthcare professional. Subjective means basically things that we feel. Something just doesn't seem right. And those clues we get from the patients themselves. Either they're very quiet, basically they're not their regular selves, and that should also be something that we should be aware of.
With those objective and subjective cues in mind, our next step is to distinguish accidents from abuse. How can you differentiate accidental injuries from those suggestive of intimate partner or child abuse?
Thank you very much. The very first part is something that is key, especially when it comes to finding out something that is just not quite the same and with the patients. Basically, the main key is to have only the patient in the operatory, regardless of the age of that patient. This should be automatic, in my opinion, for all practices and for all patients. When we think about it, the operatory can be a very scary place, especially for young kids. The chair goes up and down, sideways. We've got lights on top of our heads and so on. Ideally, in our practice, what we had was the siblings would bring their younger ones in for the very first visit. Maybe it took 2 or 3 visits and appointments before any one of us even saw the child. For the guardians, for the parents and so on, we had a chair that was quote unquote reserved for all the guardians. This was outside of the operatory, but within eyesight of that operatory that they could see inside. But any conversations inside the operatory could not be heard. This should also be routine policy for all healthcare professional offices, according to the patient privacy laws, the FIPA and PIPEDAs. And a key point is that also every sport and I'll be highlighting this again with the sports aspect. Every sport has unique injuries pertaining to that specific sport. Hockey is different than football, is different than cycling, and so on. And every accident, and I use accident sometimes in quotation marks, has unique areas on the body. It could be the face, but also on the hands and so forth. So we have to be aware of that. And so every abuse, trauma, injury is very unique by patterns and by location. So we have to note colors, location, the answers the patient give us when we ask a question, and all this is collecting evidence, basically in our notes and so forth, as part of our charting, record keeping.
And from your background in forensic dentistry, which injury patterns, for example, chokehold marks, bite wounds, or intraoral lacerations, have you found most diagnostic of abuse?
Again, thank you. The key is the pattern and the location. I often use in presentations footprints in the sand on a beach. You have a man or a woman walking with a dog. And again, we know that they're footprints, but uniquely different all the way through. So, in order to diagnose that, we have to look at things with the help of other people, maybe a veterinarian, for example, with the footprints in the sand with the dog and so forth. But it's a multidisciplinary team approach where we all have to work together when it comes to abuse, and we have to respect each other's vocations. In other words, it's not just dentistry. It could be the Children's Aid Society, law enforcement, medical doctors, emergency room personnel. We basically have to work as a team for the patients who is now the victim. So basic dental patterns, going back to the question, normally, number one, they're oval in shape, usually around 3 centimeters, going eye tooth to eye tooth. And the second aspect for upper and lower jaws, the mandible has all the power, so it leaves a much heavier bruising pattern. So that's also gives you an orientation. So all dental healthcare professionals first must recognize basically suspicious injuries where the pattern and the location is not normal, something that you just might feel is not right here. And then you have to report that suspicion to the investigative team. We'll talk about that later on as well.
Those injury patterns can be incredibly telling, but sometimes it is the dental evidence itself that tips the scales in an investigation. Can you share a case where dental evidence was essential in a criminal investigation?
Yes, again, even the podcast, but I often say viewer discretion is advised because it does get into very personal and very traumatic areas. But let me explain that with some of the highlights. One that I had was a young girl, 2 years, 3 months of age. I was called by the Hamilton Police Services and the emergency room personnel at the hospital. Basically, the story that they had was that the child had fallen down and hit her head. I was called in to look at these unique pattern injuries because there was others as well. On the forehead, there was a round pattern injury. It was fell into the 3 centimeter aspect, cuspid to cuspid, so I could kind of look at it. And basically, I saw the heavier bruising pattern from the mandible, so I knew we had a bite mark on the forehead. And again, that's as a dentist, that's our head and neck area, so the bite mark was noted. Other multidisciplinary team investigators did not see that, so we're training them as well. But as a member of the multidisciplinary team, I could also see below the neck. When we searched the rest of the body from the bottom of the feet to the top of the head, we found 13 bite marks. Unfortunately, 3 of them were on the vaginal areas. And again, 2 years, 3 months of age. There was also third-degree cigarette burns throughout the body, especially on the feet. And I found this out in court that the cigarette had to be held against the foot for 9 seconds to cause this type of pattern. The other aspect from child abuse, but intimate partner violence. Basically, we're into a criminal and sometimes very much a civil case, but bite marks are common, grabbing marks and so forth. So again, the pattern and the location is important. That's stuff that we should, as healthcare professional, mark down where these are and take a picture of them. One very simple one with a bite mark was 90-year-old female, 92-year-old female, and she had a bite mark on her left arm. Even the hospital personnel said, oh, she bit herself. But when I look at the bite, there's no way, because if she bit herself in the left arm, the mandible would have been closer to her chest, and this was not the case. The mandibular area was, away from her, so somebody else bit her. This ended up being actually a homicide because 5 weeks and 2 days later, she died of sepsis from the infection where the mandible had actually penetrated through the skin.
Wow, those are powerful case scenarios. And the diagnostic patterns seem so obvious when you point them out, but Would you agree that they're only part of the picture? The real challenge lies in conducting screening in a natural, unintrusive manner. But how do we seamlessly weave targeted medical history questions and extraoral inspections into routine 4 to 6 month recall visits without alienating patients? And secondly, what specific red flag questions or form design tweaks have proven most effective in your experience?
Actually, that's very good. If I can maybe make one correction, I'd like the whole profession to do this in a sense. 4 to 6 month recalls. To me, recall comes with my car, and I get very upset when I get a recall notice for my car. What we have in our office, we always called it a 4 to 6 month recare visit, because what we're doing is taking a look again, seeing how well they're keeping care of their mouths and so on. And it's a recare visit, not necessarily a recall that we're looking for something with that. So, but the question itself, great observations at the start. Again, we discussed the 65% physical abuse in the head and neck area. Again, the dental professional's domain, the 24% in the arms and limbs. And again, 89% is easily viewed as far as physical abuse goes by any healthcare professional, medical doctor, chiropractic, massage therapist, physiotherapist, as well as dentistry. But the other part, a key tool, and is basically asking the right questions, either verbally with the patients when they present, if they got an emergency type of stuff or something. But on the medical history forms, we use that form consistently for every recare visit, every appointment. We show it to the patients again. Any updates? Has things changed since this last time that you were here? Yes or no? And that is noted by the assistants as well. So most medical history formats, the patient fills out the form at the initial appointment. Basically, they mostly just ask regular questions. How's your heart, liver, kidneys, and so on, any allergies and medicines and so on. But there's a lot more to that. So we should also ask, we have it on our forms in regards to various things that we have as habits. How much do you smoke? What kind of smoke things do you smoke? Pipes, cigarettes, cigars, and so on. What do you drink? Is it alcohol? Is it beer? Is it coolers, and so on? How much do you drink? Recreational drugs are really a key right now between all the different ones, not just marijuana, but various recreational drugs. But most medical histories, again, do not ask these key questions, but we also ask ones that will assist us to diagnose possible abusive trauma. I think the best thing here is anybody who's listening wants a sample of that, maybe they can contact your academy to find out, get an example of our medical history forms. But on our forms, basically with that, they're reviewed at each appointment, and we ask the patient any changes, yes or no, and that's noted in their charts. On our medical history form, though, the part that is kind of telling is we have 3 specific questions specifically to abuse. Have you ever had or experienced any of the following? Just check if yes is what we ask. And if they checked 3 questions on abuse, have you been a victim of child abuse, domestic or family violence, spousal or partner abuse? There's another 11 what I call corollary questions that are associated with abusive trauma. If the patient checks off 3 or more of those 11, then we get suspicious as well. We also ask about pregnancy. You think, well, that's pretty well normal on most of the forms itself. Yes, it is. But when it comes to intimate partner violence, most of that happens during or shortly after a pregnancy. And the other question we have on our form is, what sports do you play? I'd like to know what sports they play, hockey, football, and so on. But also, especially for the kids, what position do they play? The quarterback is different than a linebacker and different than a catcher and so on in different sports, because each one of those sports has unique pattern injuries as well. The key to all this with our medical history forms, after 30 years in practice, we had a survey done from January the 1st to December 31st, and we tallied all the results we had. It depends because different times of the year, summer is different than winter and so on, but the average was between 39 to 43% of all the patients we ever saw as news or as emerges. So an average of 41%, plus or minus 2%, were or currently are abusive victims. So that is pretty telling. If we ask the right questions, we will get the answers. And so that part of the red flag is there to detect that. So medical history should be able to recognize the clues itself, but we ask the questions itself. We have to trust our gut too. Something just doesn't feel right. Yes, but it's important to catch those early ones, because one thing that with the survey has showed me, and I've taught with experience myself, the intensity and that severity of the abuse will increase with time. That slap across the face, that yelling and so forth, again, becomes a punch. Next thing you know, it's a hitting with an object. I've seen cases within 6-7 weeks where the victim from the slap across the face becomes a body on the autopsy table, and that's how fast this can work. So it's key for us to be able to be aware of that.
Spotting red flags is only the beginning. What follows can be even more delicate and complex. Once you suspect a patient is being abused, what are the first ethical and legal steps you should take?
Basically, the first thing that we as dentists should do is, our own college, the Royal College Dental Surgeons of Ontario, stresses that we must report suspicions of abuse. Recently, about a couple of months back, the RCDSO did have something in regards to dentists more or less catching other dentists who might be abusing their patients. But reporting abuse by others on our own patients and clients, if you will. Dispatch had articles about 10, 12 years ago in regards to child abuse with the Child, Youth, and Family Services Act. These are mandates by law that we as healthcare professionals follow. Unfortunately, in my opinion, few courses are currently available by any of the organizations. I'll speak more on that later on how we as dental healthcare professionals can recognize abuse and so forth. But essentially, I would call the college as a dentist, ask for what is called a dentist advisor. There's usually about 4 to maybe 6 of those available, and they're there to ask any questions you have, regardless of what it is. So phone them. They can hopefully advise you accordingly. Overall, the best thing to do is take a Core 1 course on dentistry's role in abuse recognition and reporting. And that really can show you examples of what to look for, both extraorally and intraorally, in regards to being a dental healthcare professional.
So, after taking those first steps, the next critical piece would be documentation. As dental health providers, we're mandated by the college to keep complete and detailed records of everything that occurs during the appointment. But how do we document your findings, whether notes, photographs, or referral letters, to build a clear forensic record while still respecting patient confidentiality?
Great questions. And essentially, I say to all of us healthcare professionals, we should just follow what we were taught in dental school. I think most dental schools throughout Canada, anyways, have excellent programs in record keeping. And they also go into the digital aspect of that, or the written. Again, what constitutes a record keeping? Is it models, photographs? It's all of the above, x-rays and so on. So all kinds of records are important. Proper record keeping protocols protects you also from potential litigation from the patient. If the patient says, gee, I went and saw another dentist and they said I had periodontal disease, but I've been going here for the last 3-4 years, and what's happening? Your record's going to protect you from that litigation. The other part, because of the digitization of our practices, what we always had at our chair side was just a steno book. And the assistants were told they basically kept an easy track record of what was going on, and they could take that and transcribe it later into the digital records as well. But that steno book now also becomes part of your record keeping, and it must be kept for 10 years. All dental records must be kept for 10 years. That's the college's rules. Sometimes the courts may ask the dental office to keep them for a longer period of time. That will be via a court order itself.
Once the findings are documented, the next challenge is turning awareness into action. Every dental office needs a clear practice response plan. So, what protocol should be in place for suspected abuse? Who calls 911? Who notifies child protection services? And how is the team mobilized?
Great questions. And what we need is, I often use the example, even back in kindergarten, we were taught how to respond to an emergency. And even in kindergarten, we had fire drills. The bell rings a different way in the schools. We knew exactly what to do. It might have been as simple as taking our classmate's hand and just following the teacher out. So in this regard, when it comes to patients and so on, you're suspecting abuse, the full office staff training must be also a fire drill. Do all the studies and protocols, practice it before the event occurs. It's just like in a medical emergency. Somebody has a coronary in your office. What do? Who calls 911 and so forth? We work through a protocol. There are programs that are available to help us do that as an office staff. And with that, it's also important to keep it going at least a couple of times a year anyway, every 4 to 6 months, practice your emergency response. So it's critically important that all staff, first of all, when it comes to abuse, understands and recognizes the signs and symptoms of trauma and abuse. In our office, we had a silent signaling system. We had every office, even in the washrooms, we had a light paging system. If somebody pushes, we had a variety of different colored light systems, which meant something to us. There was one light that could put the whole office on full alert without any announcements being done. As soon as that went in, we went into a fire drill, if you will. And during the practicing, when we did this after hours and so on, we would stress the roles that everybody had to be aware of and how to address them. Be the same thing as preparing again for the medical emergency, but we discuss that and practice it. So everyone knows the protocols. And again, we'd have to routinely use that so everybody's alerted. Something as simple in our office when we used the lighting system was I got a color code when I had my next patient was already had arrived and was in the reception area. We knew that that person had arrived. So use it in that aspect with routine things during the day itself. But the key in today's world with trauma, abuse, and so on, even the threats in the schools now, they all have lockdowns. We never had that back when I was in kindergarten, but that was last century. The staff, we must educate the staff on what they are aware of, and that the law says we must report abuse. The law also says we cannot be sued as long as there's no malice in our reporting. We have to be updated on new mandates, new bills, and so on that are coming out. And again, even though it's the college's, in my opinion, duty and responsibility to inform all dental healthcare professionals what's going on as far as the dentists go, but things have changed. We got new Bill 264 in regards to stalking. We have a Bill C-75, which deals with intimate partner violence and strangulation. With the office owners, by the way, there is what is called the a VQRP program as well, Victim Quick Response Program. And even though the Ontario Dental Association has kind of forensic codes, if you will, that will deal with some of the abusive aspects, it's under the 90,000 codes, the codes that start with the 9. But with that, anything that is not covered is covered by the government under this code itself. And again, it's something that hard to describe right now, but a Core 1 course should actually do that. But the easiest by all means is having staff meetings. One thing that we did at least once a year, we have a staff meeting, a working lunch for 2 hours. We usually had a police officer involved with child abuse, senior abuse, and so on in the Hamilton area. We had Children's Aid Society intake workers come in, and they sat down and we role played. So it's a learning session for both sides. And we dealt with everything right from, the young child to the teens, the adults to the seniors, all potentially being victims. So that's key. Make it a working lunch itself.
Excellent advice for the whole team. And after we have established internal protocols, staying connected to external support is just as critical. Which external agencies and legislative mandates should dental practices keep on speed dial? And how do you keep your staff up to date on reporting requirements?
Great question again. Exactly what we're talking about. Have the working lunches. A lot of that will come out in that because your staff will ask the same question to the police or the Children's Aid Societies. Gosh, if we have that, how can we help out? They have pamphlets galore that we just don't know about because we never asked about that. The community itself, too, there's one excellent program that I've worked with the local Hamilton Police Department here. We have a booklet that's probably 35, 40 pages long in regards to senior abuse. And it has all the resources, all the shelters that the seniors can have. And you can use that also with the other, child, the women shelters and so on. These are all provided all the way through. I would not necessarily provide that to the patient in our chair right now. The part of the program is to also, or process is to also have them aware that we know that something's not quite right and meet with them privately because who knows, maybe the abuser is sitting in the reception area waiting for them and so on. So people always ask, well, people are going to be afraid to come to the office. Complete opposite. When the people know that you're there to help them out is that a benefit to the practice. I have to say I'm not patting myself on the back. We had a waiting list of new patients that wanted to come in. It was usually about 6 to 8 weeks long, but basically we had a waiting list because birds of a feather stick together. And with that, they know other people that are being abused, and they'll have them come in as well because they know you care. But ask the agencies. And again, that working lunch is the best way to do that.
Staying informed is the link that ties all these efforts together from detection to documentation to action. So let's bring it full circle. How can all dental professionals and undergraduate students stay updated and empowered to recognize and respond to abuse effectively?
Wow. If anything brings things to a head, this is it. I am basically right now, after, well, almost 5 decades of doing exactly this, not just the dentistry, but working with the police, with the children's aid societies, with the various agencies, and so on. In my opinion, it takes a village. Like we've heard that how many times? We have to involve our municipal, provincial, and national governments. We have to inform our regulators and the faculties. We can't assume they know. I wrote an article for the Oral Health Journal back in September of 2024. And the main title there is We Don't Know What We Don't Know. And don't assume that we are the only ones as healthcare professionals and practitioners that we don't know what's going on. I've heard it how many times from law enforcement, from all kinds. I'd never thought about calling a dentist in. They have to know what's going on. In order to change the rules and regulations, the regulators have to do that, but they also have to respond to the government. So governments have to be aware of that. Crawlies to that as well. All the associations we have, the Ontario Dental Association, Canadian Dental Association, all the national, provincial, and even constituent societies have to be aware of what's happening in your own local municipalities. So I think of all healthcare professions to, work being part of, I'm so proud of dentistry because our whole focus, right from day one in first year dental school to the careers itself, is prevention. Whether it's putting fluoride on the teeth to prevent cavities, whether it's mouth guards to prevent the sports injuries, prevention is what it's all about in dentistry. And that should also reflect itself in regards to being able to spot and recognize early signs of abuse and catch these early, because it's going to go, like I said, the intensity and severity will increase with time. Again, in my opinion, the faculties and the regulators are key to a lot of this. They must have Core 1 courses that are easily available to all healthcare professionals, dentists, hygienists, assistants, receptionists, and so on, and be able to promote and support what our profession is up to. As updates come in, they have to be able to do that because things do change. The laws, mandates are changing. But one of the key parts is I've been to courses, and in even my own local academy just a few months back, course was given by another person in regards to forensic dentistry. Person is not what I call affectionately a drill, fill, and bill type of practitioner. We are out in the boonies there working with all kinds of different procedures for patients. As general practitioners, whether it's a specialty practice, a general practice, we deal with patients of all ages, with living patients, and within our own local communities itself. So a speaker for that should be somebody that is, knowledgeable in dealing with the public, but also with what's going on. I've seen this with our own provincial associations. They bring speakers from outside of the country, from the United States usually. The laws are different in Ontario than they are in British Columbia, but they sure are different than what they are in the States or any other country as well. The other aspect is the governments, provincially, federally, and so on, and even privately, we now have corporations that are running practices and so on. Some of these government so-called dentists, they got electron microscopes at their beck and call and so on. That is not stuff that we have available in our offices all the time. We have to know what's going on that way in the regular practice world. And that also includes the faculty. The academics are teaching the students the basics of what we need to know, but what is it out there when they get outside of the four walls of the faculty into the four walls of the general practice? What is there? The other part is critically important. Again, the staff has to attend for the Core 1. We have to work as a team, not just in the community, but also within our own practices. again, to the provincial associations, the faculties, work with your local law enforcement. Here in Hamilton, we have branches of the police department that are dealing with child abuse. We have the Children's Aid Societies. We have victims of crime, like you see on TV. We have senior abuse officers. We have to work as a multidisciplinary team with everybody working together. And with the faculties, again, getting back to them, at least minimum should be an elective course in regards to abuse recognition. The ones I've seen, there's one in the province of Ontario that does have that for elective programs for the undergrads. But a lot of ones throughout North America basically don't, and there's articles galore that I could quote you on that. So essentially, every dental organizations, right from national to provincial to municipal and so on, we have to work together with the governments, the acts and bills that are there. We have to ensure public trust. And in my opinion, sometimes we're just not getting there. So, basically, I guess in summary, all of us must understand that forensic dentistry is not just comparing antemortem to postmortem x-rays when you find some skeletal remains somewhere. Today's students are indeed just students, but they're currently not bound by the mandates and the laws that are out there in the real world. But today they're a student, tomorrow they graduate. When they graduate, they are now dental healthcare professionals, and again, dentists, hygienists, assistants, and so on. They are now bound by mandates and the law. But a lot of this was back, I graduated 5 decades back. These were never taught back in those times, and in some cases, were not being taught today. Things have changed. We have to be able to recognize that because it's happening. Open up your newspaper, it's everywhere. People are getting abused, and violence is there everywhere. And our profession could be, again, prevention. If we hit that early, we can prevent this from being a major crime as well.
Dr. Stechey, thank you so much for bringing attention to such a critical issue and offering thoughtful guidance on how dental professionals could recognize and respond to signs of abuse in their practice. It's been a real pleasure having you with us.
And we'd also like to thank you, our audience, for joining our discussion today. Be sure to follow us on Instagram at ACD Ontario and on Facebook for updates on upcoming Pillar Pod episodes released each month, including topics such as becoming and being an excellent team leader with Dr. Shri Koka, managing the expectations and demands of the prosthodontic patient with Dr. James Tonagai, and many, many more.
And that's goodbye for now from Zaira and Sonia, your Pillars pod hosts. Thanks for listening, and we'll see you next time.